All right. So we'll go ahead and get started today. So we're going to be kind of focusing on an overview of some of the common eating disorders, what causes eating disorders, what treatment options are available, and how to recognize that someone might be struggling. And before we fully get into that content, I'm going to introduce myself just a little bit further. If I can get my slide to advance. There we go. So I'm originally from the State College, Pennsylvania area, and I went to Penn State University, which is the university known for State College, Pennsylvania. I originally became interested in nutrition when I was in high school. I would say that like early on in like middle school, high school, I didn't really have like a good relationship with food, and starting to learn about nutrition and how to actually fuel my body well was something that was, really life-changing for me. So I decided to go ahead and study nutrition in college. And I became a registered dietitian so I could work with individuals to develop a healthy relationship with food and also learn how to fuel their body well for exercise. I was a track athlete in high school, and learning how to actually, fuel your body to perform well and to recover well was a really eye-opening experience. So I've had the opportunity as a dietitian to work in several different fields, including as like an outpatient dietitian, as a sports dietitian, and also as a collegiate dietitian at a couple universities as well. But during the pandemic, things got really shaken up, turned upside down, and I was just kind of working from home and noticing that, I had like a lot of clients who were struggling with different things like chronic migraines or anxiety or insomnia. And there was only so much that I could do as a dietitian to offer them, like lifestyle advice for some of these issues. So I really wanted to know, like, is there more that could be done for them? Like, do they need to be on a medication? Or is there a medication they're on that's causing some of these symptoms? And started to go down this path of wondering, I wonder if I could go further in my career and attempt to go to medical school. And it's something I had actually thought about in high school, but I think it seemed very far out of reach. I didn't have any doctors in the family. And I think I didn't really believe I was smart enough to go to medical school, but becoming a registered dietitian and becoming more confident as a professional, led me to want to give it a try. And it ended up working out. And I am now like a MD candidate at Rutgers Robert Wood Johnson Medical School, Piscataway, New Brunswick, New Jersey. And I'm just entering my fourth year now. And I'm very excited to share that I've recently decided that I'm going to apply into pediatric residency to become a pediatrician. I'm really excited about that because I think in pediatrics, there's such a good opportunity to work both with like children and adolescents, but also their parents to help them develop healthy habits, how to learn how to talk about like body image in a healthy way too, and to hopefully, be able to prevent eating disorders or disordered eating, or at least to recognize it early and help people get the help that they need, which is another area that's just really important to me. So without further ado, I'm going to get into the presentation for today. I do want to mention just as we're going along, if you have questions that you want to ask at the end, we will have a Q&A session. So if you don't want to forget a question or just want to put it in the chat, you're welcome to just put it in now or at any point during the presentation, and we'll have an opportunity hopefully to answer some of those at the end. So this is again just kind of the outline of how we're going to go throughout the day. We also will have a couple of opportunities for breakout rooms where there'll just be like, I think about 3 to 4 people or so, small groups to talk about the video that Elizabeth put together that you were able to watch before the session, as well as another video later on in the session that'll be like a short video we'll all watch together. And there will be a break halfway through as well, just so you know, because I know 2 hours is a really long time to be sitting together. So we'll have that opportunity as well. So to start us off, I wanted to touch on the difference between eating disorder and disordered eating because I think those terms, obviously they sound very similar and sometimes it's easy to kind of confuse them with one another. So for someone to have an eating disorder, this is specifically a diagnostic term where there's like specific criteria someone has to meet. in order to be diagnosed specifically with an eating disorder like anorexia nervosa or bulimia nervosa. And the American Psychiatric Association is describing it specifically as behavioral conditions that are characterized by severe and persistent disturbances in eating behaviors and that are also associated with distressing thoughts and emotions. Disordered eating is much more broad. The Academy of Nutrition and Dietetics describes it as just a range of eating behaviors that may or may not warrant diagnosis of a specific eating disorder. And with disordered eating, it's more that the eating behaviors are not consistent with like healthy eating behaviors. And it could be as simple as someone like regularly skipping meals or having like a very limited diet, or maybe even like wanting to focus on healthy eating to an extreme level without it being a focus on like weight specifically. So like the term orthorexia, you might have heard like is not really listed as a specific eating disorder, but it kind of falls under this like disordered eating category. So there can be many, many people that have disordered eating. I'd argue that, more people than not will experience disordered eating at some point throughout their life. But having an eating disorder diagnosis is much less common, although honestly, it's probably not, diagnosed as often as it should be. I think there's a lot of people that go undiagnosed, unfortunately. And we'll talk a little bit more about why that might be later. So this is just kind of a moment where we can kind of talk about like as a group, like what do we think having an eating disorder would look like on the outside? So what kind of signs would you see from someone in terms of like anything about them physically or their behaviors that might suggest they have an eating disorder? So if you want at this point, you're welcome to like unmute yourself and share an answer, or you can type it into the chat. And it's no right or wrong answers. It's just kind of like what comes to mind. Yeah, it would help someone be skinnier. Yeah. Their mood might change. Yep, absolutely. Continuously counting calories and never letting themselves enjoy the food they eat. Not having meals around others. Yep, isolation with meals. And yeah, exactly. Someone avoiding social situations that include eating, dissociative relationship with eating. And yes, very good point, Ashley. It can affect many areas of life, not just related to food, engaging in binging or purging, weight changes. You guys are doing awesome. This is so good. Constant exercising to burn calories, avoiding certain foods or obsessively thinking about it. Yeah, very good. Yeah, hyper focus on food, distracted during everyday tasks. Okay, that's awesome. You guys came up with such a good list. So I'm going to highlight some things here that are, again, like things you might see kind of from the outside of someone that might experience an eating disorder. So again, this is not all inclusive, but this is going to hit on a lot of the things that you all already pointed out. So a big thing we definitely see is the reduced spontaneity or flexibility concerning food intake, often seeing like more rigid patterns or behaviors and feeling very stressed about changing those patterns, especially unexpectedly. Avoidance of social situations with food, a lot of people mentioned. Sometimes we can see like a hoarding of food or like rationing food for the end of the day. So we can see that a little bit more sometimes with like bulimia or like a binge purge disorder. Sometimes we'll also see eating foods like in a specific order, like food rituals, or like making sure foods like aren't touching each other or always eating like every food with like utensils. And then more of like the physical side effects too could include changes like dry hair, skin, or nails, which can be signs of malnutrition, significant weight changes, and we mentioned the mood changes as well. So you guys hit so many of these, which is awesome. And then this next slide is like kind of a related question. I'm going to go ahead and just go through this because we actually included some of these answers as well. But yeah, in terms of like what it might feel like on the inside to have an eating disorder, definitely like constant thoughts about food and body weight can occur that can really disrupt like quality of life and sometimes can affect performance in school or at work or social relationships. Often there's this inability to really define like hunger or satiety or kind of this disconnect between like hunger and fullness cues. And then especially as things progress, as we start to like see like either like decreased food intake, decreased energy reserves, poor concentration, and fatigue can occur as well. There's often this feeling of never feeling good enough or satisfied by the way they look. And then again, more of the physical symptoms we can start to see would be like a cold intolerance, especially with like low body weight or significant weight loss. And then delayed gastric emptying or feeling really full after small amounts or easily experiencing like constipation and bloating is a very common experience. And I do want to highlight the other side of this that can happen, which is that for some people that have an eating disorder, sometimes the eating disorder can feel like having a sense of control or being able to numb their emotions or awareness of what's going on around you, and in some ways feeling empowered in a way that you hadn't before. And these parts are what sometimes makes recovery really hard, especially for someone that might have a restrictive eating disorder. They might at sometimes feel like everything's okay and not really feel like there's something wrong that's bothering them or disrupting their quality of life. And in fact, they might feel like their life is better with the eating disorder. And a lot of times they're not able to fully see that, the whole situation. They're not able to fully recognize like the severity of it, but that mental piece of like not always being able to see like the negative sides of the eating disorder can make recovery hard initially for a lot of people. So we're going to take a little break here to do our first breakout room. So like I said, we're going to have small groups of people, and this first breakout room, we're going to be discussing some questions related to the video that Elizabeth put together that all of you should have watched in advance of this session. So we're going to do the breakout rooms now, and we'll do that for about like 5 to 10 minutes, and then we'll all reconvene after that point.
Awesome. So I will be in one breakout room. Ariel will be in another. Elizabeth and Tiffany, you will both be in one together. And then Nicole, you'll be in one. Dr. Marcella, if you want to be in the same one as Nicole, I could put you in there. All right. So let me create 4 breakout rooms for everybody. And
Lynette,
uh-huh.
could you put me in the same room as Elizabeth?
Yeah, for sure. Okay, so you'll
Okay,
be with Elizabeth and Tiffany then.
great, thanks.
No problem. Okay, let me just adjust that then. All right, so I'm going to open all the rooms for you all. Hey, everyone. Okay, Nicole, I think everyone's back now. If we want
Okay.
to have a big discussion with everyone.
Yeah, so yeah, just to summarize for my group, there was some amazing discussions about like social media and things that we see on there, what can lead some people to have like misconceptions about like what's realistic for, body shape and size or what they should be aiming for like total calories in a day. So I think it's really great that we're at least starting to like uncover, some of these you know, yeah, misconceptions or lies that are on social media, unfortunately, and kind of finding out ways to like pinpoint like what might be, something that's more of a deception with like Photoshop or like not really giving like the whole story and what's not like applicable to everyone versus just like one person on social media. And we talked about how, like, with the video that we watched, also just trying to increase awareness with like school nurses about how to, properly help those that are struggling with eating, and also coaches as well, especially for sports where weight or aesthetics are like a big part of the sport, how they can appropriately support athletes. So like I'll share more thoughts, and like feedback, like specifically notes with Elizabeth and everyone too at the end, but it was an awesome discussion. So hopefully everyone else had that as well. Oh, and I saw Ariel said in their group, they were about to ask what positive influences we have around body image that encourage us to be healthy. Yeah, I think that's a great question. So does anyone want to share like any positive influences around like body image that they have?
I feel like this is corny or like weird, but it's like my favorite band because like they a lot of times they talk like people would like comment on like their lives and it'd be like, oh, I should like lose weight before I go to your guys' concert. And they're like, what are you talking about? Like you look just fine. So like for me it's like yeah, my favorite band. I went to a concert last month, so that was really fun. But yeah.
What
There's
band is that, if you don't mind me asking?
it's called Stray Kids.
Okay,
But yeah, I got to see them in New York. So it was fun.
awesome.
There's also like some like very like body positive influencers. Like one of them is really famous, like Spencer Barbosa. Like she did a campaign for Hollister as well, I think. She posts a lot of content about like body positivity and things.
Okay, awesome. Thank you. All right, well, if anyone thinks of any other ones later, especially, yeah, if it's any like influencers or people you follow online, definitely feel free to share that. We're always looking to learn about people that are actually spreading positive messages. Oh, yeah, yes, Fiona Mayer, absolutely. Yeah, she has been like awesome to watch since the Olympics. Yeah, thank you, Ariel. All right, so I'm gonna return back to the PowerPoint for right now. Okay, so the next piece that I wanted to just touch on briefly are the four most common clinical eating disorders that we tend to see in practice, just about what are the criteria for each and what can be sometimes some certain like complications we might see with each of these. So for anorexia nervosa, this is defined specifically as a significant restriction of energy intake that leads to either a low body weight, which is defined as like a BMI of less than 18.5, or significant weight loss in a short amount of time. So as an example, this could be like losing 10 pounds in a month. And then associated with these weight changes, there's also an intense fear of weight gain or becoming fat, and then often a distorted view of body image or denial of the seriousness of the weight loss or the low body weight. And just wanted to put kind of as a side note that sometimes, unfortunately, this distorted view of body image or not understanding the seriousness of the condition can be perpetuated by like healthcare professionals or coaches or parents. And I think this is especially true for what we would call like atypical anorexia nervosa, where someone is starting out in like a larger body size and loses weight, but then isn't in that like underweight category. So just as an example, like if we had someone that was starting out at 5'7" and 200 pounds with a BMI of 31.3, if they then were to lose, like, let's say 40 pounds in 4 months, which is a very fast rate of weight loss and would not be considered safe, their BMI after that would be like 25.1, which is just right over the cusp of like the overweight category, almost the normal BMI. And I have seen instances of like healthcare providers like congratulating pediatric patients for losing weight like this and not really like thinking about the rate of weight loss and how unsafe that is and maybe what's like motivating that weight loss rate because the motivation is really important too. And then I did want to mention it used to be a criteria for anorexia nervosa for there to be loss of a menstrual cycle for 3 months or more, which is defined as amenorrhea. That's no longer a necessary criteria because A, it's not just females that develop anorexia, but also everyone's body is a little bit different. So sometimes we might see significant weight loss and someone is still getting their period. So that is not a criteria anymore, but the top 3 points here are the most important ones. And then with bulimia, the diagnosis for this requires two specific criteria. So it includes binge eating, defined as consuming a larger amount than normal for that person within a 2 hour period, along with that feeling of being unable to stop eating. So it really feels like a loss of control during that time. This is then followed by some kind of compensatory behavior, which can be self-induced vomiting, laxative or diuretic abuse, excessive exercising, or a period of food restriction. And then this cycle of like binge eating with compensatory behavior occurs on average at least once a week for 3 months in order to meet the criteria. Binge eating disorder has the same like binge criteria as bulimia nervosa, but there is no compensatory behavior afterwards. So this kind of just goes through a little bit more of like what the binge episode is typically associated with. So it's, in addition to feeling like out of control during that episode, it's also eating much more rapidly than normal, often feeling embarrassed or guilty about the amount of food eating and wanting to like eat in secret or away from others. And then often feelings of like depression or like low self-worth afterwards. And then as with bulimia as well, there's often like marked distress over the binge eating behavior during these episodes. And these behaviors also have to occur on average at least once a week for 3 months in order to meet diagnostic criteria. So just to clarify too, when I had talked about like things not meeting criteria, we have this kind of like catch-all phrase called like OSFED or like I actually forget exactly what it stands for, but it's like eating disorders like not otherwise specified. So like if someone had like binge eating disorder like criteria that was almost met, but they only did it like once a month, for example, they'd be considered to have this like not specified eating disorder. It doesn't meet like the exact criteria. And then ARFID's the fourth one. This one is less common, but it's something we're seeing more often, I would say, diagnosed. So this one is able to present in a few different ways, but it's defined as an eating or feeding disturbance that's not explained by lack of access to food or another medical condition like a GI disorder, like inflammatory bowel disease or irritable bowel disease or something like that. But it leads to a clinically significant restriction in energy intake and also significant weight loss. And also could be dependent on enteral feeding or like oral nutrition supplements to get food that they need, like Ensure or something similar. And then also can lead to interference with like psychosocial functioning or the ability to, you know, be in social situations, especially ones that involve food. And there's three main presentations that we can see with ARFID. The first one is more of like selective eaters that are very sensitive to like the smell, taste, and textures of food. So they have a very limited diet for that reason. And they might have what we call neophobia or fear of trying new foods. And a lot of times we can see like an overlap here with this type of ARFID with a diagnosis of like an autism spectrum as well. Another presentation we might see is just low appetite and disinterest in eating. So just not feeling hungry really ever, not being bothered by not eating, and not interested in eating really any kind of food. And the last one is more of a fear of experiencing like some kind of adverse consequence when eating, like fear of choking or vomiting, which is often due to having some kind of adverse experience when they were younger that then leads them to kind of like obsess about this and fear that it's going to happen to them again. And a big distinguishing feature of ARFID from other eating disorders is there's not a focus on weight or a distortion of body image. We're just having a significant decrease in food and weight loss related to one of these other reasons that is listed here. So I wanted to stop for 1 second before I continue, but does anyone just have any like burning questions about these disorders before we continue on? Okay, I'll continue then. If you think of anything, like I said, you can put it in the chat for later as well. And then I wanted to touch briefly on like possible complications from some of these disorders. So with anorexia, a very common thing we can see is thinning of the bones, which can lead to like osteopenia first, which is like a weakening of the bone, and then eventually osteoporosis, which is like a true loss of like bone mineral density, which when it occurs is often like permanent and very difficult to reverse, especially as someone gets older and gets kind of out of that period of growth where they're able to actually add more bone mineral density. And we're usually seeing this for really a couple of reasons. It can be because partially there might be low levels of calcium and vitamin D in the diet, which are really essential for building strong bones. But also, like for females in particular, as they're losing weight and losing body fat, estrogen levels are going down. And estrogen is a hormone that's really important for our bone mineral density. It's one of the reasons that, like for women, when they start to go through menopause, estrogen levels are normally dropping. And then because of that, we see more increased rates of osteoporosis. So we can see a similar thing here with low body weight and excessive fat loss in anorexia nervosa. Anemia is due to like low iron levels. So we have in this instance low red blood cells, and we need iron in order to help our red blood cells send oxygen all throughout the body. If we have a low number of red blood cells, that can then lead us to feeling fatigued, having brain fog, and just not really having the energy to do a lot of things we want to do throughout the day. Muscle wasting and weakness occurs because our body has a need for protein that is constant every single day. And unlike carbohydrates and fat, we don't really have any reserve of protein in the body. So if we're not eating enough protein from the diet, our body's only option to get more protein is to break down muscle. And unfortunately, in like really advanced cases, this is not only involving breaking down like skeletal muscle, but can also lead to the breakdown of like some of our organs that are made of muscle, like the heart. We also can see delayed puberty or just interruptions to the normal reproductive cycle. So we had talked about how like amenorrhea, for example, can be something that we see. Other times, if we see an eating disorder starting really young at like 11 or 12 years old, we might see that a patient isn't actually progressing through puberty at the times that we would expect them to. A lot of times, if this is addressed early enough on, we can, reverse that and restore them to a healthy functioning. But if this is going on for a very long period of time, it could lead to more complications later on, like infertility, and also like decreased height over time as well. And then we talked a little bit about some other complications like the constipation that can happen through just like slowing down at the GI tract. We can also see like low blood pressure or difficulty maintaining proper blood pressure when going from like sitting to standing. We also will see sometimes slowed breathing and pulse, essentially the body trying to conserve energy in this really low energy state. And then in more severe cases, we can see heart arrhythmias due to nutrient deficiencies, especially of certain like electrolytes like potassium, sodium, and magnesium, and phosphorus. And then with bulimia, some of this depends a little bit on what the person's engaging in for like their compensatory behavior. But if they were engaging, for example, in self-induced vomiting, what we can see from that would be chronically inflamed or sore throat. In very like severe cases of like forceful vomiting, we can see like rupture of the esophagus, which is like a medical emergency. We can often see swollen salivary glands, especially kind of in this like neck and jaw region from like the repetitive vomiting. And then also worn tooth enamel or like very sensitive and decaying teeth. Acid reflux is common as well. And then just general intestinal distress and irritation, indigestion. And in very severe cases, we'll see like significant dehydration and electrolyte imbalances. And we can also see dehydration and electrolyte imbalances for just like abuse of laxatives or diuretics as well. So I just wanted to show like a few physical exam findings that you might see. So like Russell signs is something that you might be able to look for if someone's like using their finger for like putting their finger in their mouth for self-induced vomiting, like these specific kind of cuts you might see on their knuckles if they're doing this on a regular basis. The middle picture is showing examples of like what the dental erosion could look like from like the acid coming up from the stomach over and over again. And then the picture on the right side of the screen is just showing an example of that more like swelling of the salivary glands or the parotid glands for someone as well. With binge eating disorder, again, this is, the binging episodes without compensatory behavior. So sometimes what we might see with this is if the binge eating disorder is associated with weight gain over time, we can see more of the, associated chronic disease complications that can come with like high levels of food intake that especially are associated with like high blood sugar levels or high cholesterol levels that can lead to some of these other issues down the road, like type 2 diabetes or cardiovascular problems. Sometimes if someone also then is having issues with excess weight, that's causing like the weight to press down on like their breathing, during the night and giving them difficulty breathing. They could have sleep problems like sleep apnea. And they could also have gastrointestinal symptoms here as well, like acid reflux or bloating, or even diarrhea, just depending on like the foods that they're eating and their body having difficulty with digesting like large amounts of food. With ARFID, we can see some things that are pretty similar to anorexia just because, again, it's associated with like significant weight loss or like lower body weight often, and definitely associated with malnutrition due to like limited food intake. So a lot of those similar things I mentioned with the anorexia, we could also see here as well. All right, so we're gonna take a brief break here, just like a 10-minute break if you want to like turn off your cameras, eat a snack, go to the bathroom, anything like that, feel free to get up. And we'll come back and reconvene around like 11, 12, and we'll get started again, okay? Question, I think. Oh, sorry. One really important thing that I think is important to discuss is that like what causes eating disorders, what can lead to their development, and what's something that someone could be looking out for that could predispose someone to developing an eating disorder. And as we have touched on before, actually, in some of like the breakout rooms, the development of eating disorders is multifactorial, and there's never just like a singular cause. But there are a few different factors that tend to occur. And a lot of times, if someone does develop an eating disorder, they'll have at least a few of these different factors as part of like the, beginnings of the eating disorder behavior. So these factors include genetics, neurobiology, personality and psychology factors, as well as social factors, which I've broken down into two categories, macro and micro level. So I'll talk about each of these and describe how these can each influence the development of an eating disorder. So one thing I have been really interested to learn about in the last, decade or so is the significant influence that genetics has on eating disorders. So some of the studies that have been done recently have shown that for anorexia, for example, it's shown to be 50 to 60% heritable, which means that you can trace about 50 to 60% of the genes for someone that has an eating disorder being passed down from generation to generation. So just to put that in like more specific terms, if you have like a female that has a relative with anorexia, they're 11 times more likely to develop that disorder than someone that doesn't have a relative with it. And then we see a very similar heritability for bulimia nervosa. These two eating disorders have been studied the most, so we have like the most information in terms of genetics on these two. But it'll be interesting to see what they also find with like binge eating disorder or ARFID over time. Now, just like an important note I want to make is that, if someone has a family history of someone with an eating disorder, that doesn't mean that they're destined to develop it. It just means that if there's, other factors in their life that might contribute to an eating disorder, they might be more likely to develop it than someone that doesn't have that family history. Neurobiology is another like really interesting piece to this. So, just as a definition, neurobiology is the study of the brain and how it works. So, specifically looking at like different neurotransmitters and how they are different in individuals that have an eating disorder versus someone that doesn't have one. So, what we've seen in studies that have been done over the last decade or so is that there tends to be a lot of dysregulation in reward pathways in response to certain feeding and eating behaviors for someone that has an eating disorder. So, just as an example, one study in 2011 looked at individuals with binge eating disorder and they showed like pictures of like food and measured their dopamine response, which is a neurotransmitter that is linked to, release during like experiences that are meant to be like rewarding and like our body wants to encourage us to engage in those behaviors over and over. So for an individual with binge eating disorder, they were found to have a higher level of dopamine release when viewing food stimuli compared to someone that was a similar weight to them but didn't have binge eating disorder. So we could see these individuals with binge eating were having this stronger response when they even just saw food, this stronger encouragement essentially from their body telling them like, you should eat this. This is going to be really good. You should have more of this. A review also in 2019 showed abnormalities in dopamine for individuals with anorexia, but in this case, we actually saw a decreased activation in response to food cues, particularly under periods of high stress or high cortisol levels compared to individuals without anorexia. And this makes a lot of sense because for a lot of the clients I work with, a lot of them I know, like when they are under high periods of stress, which can often be, a really frequent occurrence because they tend to be like very high achieving perfectionist individuals that are always like involved in a lot of different activities or high level classes or sports. And when they're feeling extra stressed, they usually have no appetite and really no interest in eating food. So they have really kind of this opposite response compared to individuals with binge eating disorder. And then there was another review that looked at positive emotion regulation in anorexia nervosa and saw that for individuals with this disorder, we can actually paradoxically see dopamine become high during periods of hunger or starvation, which creates this positive association with restricting food intake, which again makes recovery difficult in some of these instances. And if you want to read any more about this, I thought this was like so interesting. But the study that talks about this also introduces this concept of the adapted to flee famine hypothesis. So just to talk about that a moment, we always kind of have this question, I think, of like, why do certain like conditions perpetuate throughout society? Like, why do we see like eating disorders, for example, continue to be something that, we are seeing generation to generation? And of course, there's different reasons for it, but it in this like hypothesis kind of compares it to like how we have like other medical conditions that perpetuate that have some negative effects associated with them, but also maybe at least at some point a potential benefit. So we can compare this to like individuals that have sickle cell disease. So for individuals that have sickle cell, this condition causes their bodies under certain conditions, especially like dehydration or infection, to have red blood cells that sickle or change shape in a way that can cause a lot of different problems and disrupt blood flow and cause pain, as well as decreased oxygen delivery. However, a lot of these individuals that have sickle cell disease live in areas like Africa or Southeast Asia where there's high levels of malaria, and sickle cells are resistant or more resistant to actually getting infected with malaria. So there's like this genetic reason that we have sickle cell disease kind of perpetuating throughout all these generations because it did really serve a very specific benefit to these individuals in terms of being more resistant to one of these really critical diseases in that area. So adapted to flee famine is this idea that like maybe there was a reason back generations and generations ago that some people had this adaptation where during periods of starvation, instead of being like low energy and not wanting to go out and get food, they actually felt abnormally high energy and they felt good during that period of starvation, such that maybe they were still able to go out and do things for their tribe, maybe even go and get food for other people. So it's like a really interesting theory, and something that I think is interesting to think about in terms of like where anorexia might have started and why it might have continued throughout generations. And then the third thing I want to talk about is like personality or psychology. So with anorexia, as I touched on previously, a lot of times we can see common traits with individuals that develop anorexia. So a lot of times we will see like perfectionism, high achieving, very driven. We can often see co-occurring disorders like anxiety, obsessive compulsive disorder, and also depression as well. With bulimia, we tend to see more like impulsivity. So this can also manifest then in like substance abuse disorders or ADHD. And we can also see depression and anxiety here as well. And then I think it's always important to note that for individuals that develop eating disorders, having some kind of traumatic life experience can unfortunately be like a common occurrence. And having a traumatic life experience will increase the risk of developing an eating disorder. One study showed that 43.8% of individuals with an eating disorder had a traumatic life experience compared to 24.9% of the general population. So as we kind of talked about earlier, sometimes like the development of an eating disorder, part of the reason it occurs is like it helps that individual to kind of like numb from emotions or to kind of like adapt in a way that is ultimately maladaptive, but in the moment serves a purpose after experiencing something really traumatic that helps them to feel like they can kind of move forward or have a sense of control in their life. So acknowledging that trauma piece of it is a really important part of recovery for many individuals. And then social factors, like I said, I divide this into two. So, like on a macro level, this is kind of just like, all the different social factors from people that you don't even really know in real life, like social media, for example, and just people that you see online or on TV, or that you even just observe out in society that you don't really know personally. So this really focuses on like societal trends and different things on social media that are kind of considered to be like, hip or trends that people are following, like certain body ideals, certain food trends. And these things can really influence a lot of people in terms of how they think about food or body image or how motivated they might be to exercise as well. And this also can include like cultural influences. So I know for some of my, clients that are from certain areas, like whether they're from like South America or Asia or Africa, they can have like different cultural ideals that they're a part of that are really focused on certain ideals, whether it be like having a curvy body or having a very lean and thin body. And that in and of itself can be like a really significant influence too, especially if someone has like a really strong cultural connection. And then more on like a micro level with social factors are like the people you are interacting with like on a regular basis day to day. So this can include like your peer group, this can include parents, coaches, healthcare providers, and then especially, as we touched on earlier, we can see like a significant impact for individuals that are involved in sports that are focused on either appearance, size, or weight. So again, this is not like all inclusive, but ones that I see commonly where eating disorders will pop up would be like gymnastics, figure skating, dance, rowing, because rowing is another sport where you have weight classes similar to wrestling. And then, of course, cross country can be common as well. There's often this focus on like the smaller you are, the faster you're going to be, which of course is not the case. And we can see eating disorders, of course, in any sport, but these are ones where we tend to see it a little bit more commonly. So I'm going to play like a short video that's like 3 minutes that we're all just going to like watch together, and then we'll have a second breakout room after that to share our thoughts on the video just in general, but also just to touch base on anything that has come up as we've been talking about these last few slides.
Nicole, we did have one question in the chat.
Oh, sure. Let me see.
You need me to read it out? I can read it out
Yeah,
for you too.
sorry, I couldn't find
Okay,
it.
no, you're cool, you're cool. What kind of traumatic events have been found to trigger eating disorders?
Yeah, I mean, it could be a variety of things. Like sometimes it can be like experiencing like sexual abuse or trauma or emotional abuse. It can even just be witnessing something traumatic. So whether that is, being in a home where there's like substance abuse or like spousal abuse, that can be very traumatic and can be a situation where someone feels out of control. It could be like bullying. So there's like a lot of different things that could kind of fall under that umbrella of traumatic experiences. Yeah, good question. All right, I'm gonna see if I can play the video. Let me just make sure that I'm gonna share, I guess, the right screen when it pops up, but try
And sound. There's like a little button on the side where you can press to share sound
Oh, okay.
if the video has sound.
It has sound. Let's see.
At Burger King, you're the
So let me just see here.
celebrity, so you rule the menu. Introducing your barbecue brisket Whopper. It's juicy, crunchy, tangy, and imagine.
I think with eating disorders,
So I just want to pause. Can you hear the sound or no?
Yeah.
Okay, perfect.
people think it's this aspiration to be skinny, and there's
Oh, wait.
definitely
Are you sharing the video? Oh, wait. Yeah. Okay.
times
Perfect.
having an eating disorder. It's not, restricted by gender, race, class.
The reality is that eating disorders are very complex and they're mental illnesses.
Eating disorders go far beyond someone's actual body, and they go far beyond food. I look at them as a source of control when your life is kind of spiraling out of control.
I definitely believe that an eating disorder is like having a friend in your brain. And you kind of start off with this friend thinking that she has your best interest in mind. And as you spend more time with this friend, you notice your life getting smaller and smaller, and you notice her getting meaner and her demands getting harder, yet you're trapped with her.
Starting in my teens.
The age of, I want to say around 15, I remember specifically dealing with this maybe like sophomore year of high school. I first remember struggling with body image when I was about 8 years old.
When I was about 12, I definitely was more in tune with other people's bodies.
I definitely had anorexia, although I didn't know that I did.
It very much was a sense of control when I had the way that I was coping with it was to eat less, to kind of just disappear in a sense.
In my case, my body physically changed. People started complimenting me on it. You know, in a healthy mind, you hear those comments, you'd think, oh, there's a problem. And I was so sick that hearing people kind of recognize my sickness felt really good.
Having obsessive compulsive disorder, but also like living in the kind of household where conversations about mental health were really taboo. Feeling like I couldn't really open up about what I was struggling with. In some ways, I felt like I didn't really have a choice but to numb out. Beyond just being like queer and transgender, I think being a kid who ended up having mental illness, a lot of things that like I think most parents, even supportive parents, aren't prepared for, I think really threw them for a loop. I internalized this idea that everything that made me different from my family made me a problem. A lot of how I coped with that was to just repress and ultimately try to like conceal who I was.
I think just being a Black woman, you kind of move through the world a little bit differently. When it comes to body awareness, like I think as a very young child, I kind of recognized that my body and the way that people viewed me was going to be very different. Most of the time it was people saying like, you're getting curves now, like you need to make sure you portray yourself a certain way or else people are going to look at you differently. I think because of that, I wanted to take control of myself, and instead of finding positive ways to do that, I kind of self-harmed as a way to like shrink myself, make myself literally physically smaller in order to not take as much space so that I wouldn't be viewed in that way. I got even more serious about dance when I was a junior in high school. So when I was like 16, 17, I didn't see anyone who looked like me in dance magazines and dance companies. I felt that if I wanted to have a chance at a career, that I had no choice but to change my body. It was about a lot deeper things like my trauma history and anxiety and depression and perfectionistic personality and things like that. But dance really was a big part of it and really did add to that. I think a lot of people think it's like you're all of a sudden recovered, but a lot of ups and downs where I was like, okay, I'm doing good this day, and then the next day I might not feel so great. You just make sure that you're at least trying and, getting the support that you need.
I had this idea in my mind that I would know if I needed help, but what I've realized with time is that oftentimes it requires an intervention from people around you. And a lot of times it's been me catching up and only in hindsight realizing, okay, that actually was really scary.
I think we always let it get to the worst point before people turn a corner. But I think noticing these things and saying, I'm struggling, and asking for help from someone that you trust.
While it's, sometimes viewed that asking for help is a sign of weakness, it's really the opposite of that. Asking for help is a huge sign of strength.
Looking back, I see myself and wish I could shake myself and say, can't you see something's wrong? But you can't. It's not your fault if you have a sticky relationship with food or exercise. You didn't do anything wrong. You deserve support. You deserve to get better.
All right, so we're going to go next to our second breakout room. So this is going to be just, again, an opportunity to just share any thoughts you have on the video, anything that you noticed, or anything that you want to share that you've just thought of at this point, in our discussion today.
Awesome. Let me recreate the breakout rooms. Let's do like just 7 minutes work. So that brings us to like 11:40 for the breakout rooms. Okay. All right, I'm gonna recreate them. And should be open.
They're able to get out, that they're able to get out more through these other means. And then I always like to mention that like part of the eating disorder treatment should also include talking at some point about a consistent healthy exercise routine because many people will engage in unhealthy exercise practices. And it's really important to teach them what healthy looks like because it is important for overall health and wellness to engage in physical movement, but you want it to be for the right reasons. It should be something that they enjoy and it should be motivated by wanting to be healthy or to be stronger or to, be more flexible or whatever it is versus being like thinner or fitting into a smaller body size or to punish themselves for like, eating certain foods, right? So that isn't always a part of every therapy program, but it's something that when I've worked with clients in an outpatient capacity, I always try to focus on, especially for my clients that come from an athletic background and really do want to return to that sport someday. They really do have a positive association with it and want to know how they can do it consistently. So it's always important, I think, to have that as part of treatment. And then, of course, developing a consistent, healthy meal plan and a healthy relationship with food is a really important cornerstone. I put weight stabilization here with a asterisk. This might be something that's part of the program, especially if someone has lost a significant amount of weight. Unfortunately, there's a lot of insurance companies that kind of use weight stabilization as a criteria to lower the level of care for a lot of individuals with an eating disorder, which is always like really frustrating because obviously like somebody being at like a healthy weight is not indicative that they are recovered and don't need support anymore. So it's always like a little bit of a sticking point with me, but obviously sometimes this is part of the recovery process and something we might monitor. And then lastly, medications might be part of treatment to address like co-occurring disorders, like if someone has anxiety or they need like an antidepressant, but there's not like a medication we ever give specifically that addresses like body image distortion or something like that, for example. It's just more part of like the supportive process of recovery. And then just briefly, I want to touch on the different treatment options for eating disorders. There's 5 main levels of care, and the way they're presented here goes from like the most intensive, highest level of care to the lowest level. So we'll start with inpatient. So inpatient level of care is for patients that have some kind of like medical or psychiatric concern that requires like medical monitoring on a 24-hour basis. So for like a medical reason, this could be like having an obvious on lab work, like electrolyte disturbance or an arrhythmia of their heart that's found on like a EKG or electrocardiogram. If they also have just a very low body weight of like 75% of their ideal or less, or abnormal vital signs like really low heart rate or like blood pressure instability. And of course, anyone that's had like a recent suicide attempt or suicidal ideation would require inpatient. They typically would actually go to inpatient like behavioral health and then later be transferred to like an inpatient eating disorder program if that was part of their care as well. And then finally, if someone just has like very poor motivation for recovery, they really don't have like good insight into their eating disorder and don't really want to get better, but they're significantly compromised and need that support, they might have to go to inpatient in order to have that ability to make progress and complete meals. And then we also can see that sometimes if there's just like a really unstable home environment where they can't get the support they need at home, sometimes inpatient is a good way to go for these patients. Residential is similar to inpatient in the sense that it's still 24-hour support, but it doesn't offer that same level of like medical care that the inpatient would. So these patients at residential don't need daily lab work. They don't need like a nasogastric tube for feeding. They don't need IV fluids. So this is an environment where they're still going to have access to like a medical doctor, but they're not going to need medical care like around the clock or like on a daily ongoing basis. And usually there's a little bit more better motivation for recovery here, but it's usually still on the lower side where they need a lot of support. PHP stands for Partial Hospitalization Program. So this program, the patient does go to a facility usually 5 days a week, and they go pretty much all day, like 7 or 8 hours a day, but then they go home in the evening. So it provides a lot of support still during, breakfast, lunch, and other snack times during the day, but then they need to have that stable home environment where someone else is there to help them with support with dinner and of course on the weekends as well. I put for this last one that living near a treatment center might be important for engaging in PHP, but there are also some programs that offer virtual options. So in certain cases, that can open up more opportunities to engage in this level of care. And then IOP is intensive outpatient. So this is similar to PHP, but it's less. So it's usually like 3 to 5 days a week for maybe like 3 to 5 hours a day. So at this point, if someone's at this level, they usually have pretty fair motivation for recovery. They can, hold themselves accountable to a point, but having that ongoing support with groups and individual sessions is still really helpful for them. And they also, again, still need like a really supportive home environment. And then the final level would be outpatient. So at the outpatient level, there's not like a structured group component, but there is a treatment team still that would usually include like a dietitian, a medical doctor, and also a therapist or psychologist or a social worker. And it might also include a psychiatrist as well if there's a need for like medication management. So at the outpatient level, this person has to be, overall like very motivated for recovery. They can follow their eating plan without a super high level of support, just, some touch points here and there. And they can self-regulate disordered thoughts and impulses on a pretty consistent basis. And then I will include at the end a list of all of the different treatment programs in New Jersey, just so you guys have that if as a reference, in case that's ever helpful for you or for anyone else in your life. And then just briefly want to touch on, we see like significant improvements in treatment outcomes the sooner treatment is started, especially if we can initiate it in the first 1 to 3 years. So there have been studies that have looked at like for individuals with bulimia, if they get help within the first 5 years of the beginning of the eating disorder behavior versus 15, and what their treatment outcomes and recovery rates are. And you can see how significant the difference is. And I've definitely had clients where I've worked with them, just a few months after behaviors have started, and it, is significantly improved after sometimes even just like 6 or 9 months working with them. I've had other clients come to me in their 30s and behaviors started when they were 15. And it's a lot harder to change those behaviors because they're just so ingrained in what they've been doing for years. So just a really important note that if you ever know or think that somebody's struggling, it's really important to try to reach out and help them sooner rather than later. And as we have talked about a lot today, a lot of the reasons people don't seek treatment or don't get the treatment they need is either due to stigma they're facing about their eating disorder or misconceptions about like the seriousness of it, the options that are out there. And sometimes it can be a true lack of access to care, either through insurance or for other reasons. So if you are ever concerned about someone, I always just recommend trying to use I statements like, I'm concerned, I am noticing like, that you're not as happy as you used to be, or I'm worried that you're not, fueling yourself as well as you used to. Like basically trying to take a very non-judgmental approach whenever you're trying to offer your help and concern for someone. And just always kind of, telling someone that you're there for them. So even if they're not really wanting to accept help then, maybe they will later. And you can always encourage someone if you're concerned to like reach out for support to other people as well, like their parents or counselors or another healthcare professional. And of course, if you're ever acutely concerned for someone's safety, you don't have to wait for that person to tell you like that they want help. Like just absolutely go and tell like an adult or call 911 if you're worried that somebody is acutely in danger for their physical or mental health. I will also provide you with like a list of resources at the end too that does list some of my like top recommendations for like websites, books, social media, podcasts that are really great for like eating disorders in terms of like body positivity or positive food messaging. I want to just mention that for social media, Linked to Nutrition is someone that doesn't focus specifically on like eating disorders necessarily, but she's a sports dietitian and she puts out great information for people that are athletes and also battles a lot of misinformation, marketing madness online. So she's awesome to follow as like a resource for that. So I don't know that we have time for this case scenario. I might have to skip over this. I want to make sure we have a little bit of time for questions, but hopefully, in our discussion today and seeing the video, you might have some ideas about like what to look for that could be concerning and how you might reach out to somebody if they're struggling with eating concerns or with body image. Okay, so I know we just have about 6 minutes left. So if there's any questions that anyone has in the chat or that you just want to unmute and ask, we can take those questions now.
Nicole, this is Steve. I just want to just number one, just thank Elizabeth for doing a presentation and for host and thanking you guys for hosting the video. But one question I know Elizabeth wanted to ask, and I know we didn't probably ran out of time in our group, but she's doing a presentation. Elizabeth is doing a presentation for nurses in a little while, and we want to get their input on the best way to do early intervention, just to your last point. So I would just like to put it out there for the group, and maybe you could answer later and just email back Lynette or yourself. Just what do you think is appropriate for a nurse or a teacher to intervene with someone they're concerned about? I mean, it sounds commonsensical, right, in a way, but in some ways, it's always that balance. You don't want to be too invasive. You don't want to be too you don't want to over intervene either. But I'd like to put that out there for everybody in this group to, send out your opinions and voices, and maybe to yourself, what do you think is appropriate for a nurse in school who has to do multiple functions, obviously. Yeah.
Yeah, I think that's a great question.
Thanks.
Mhm.
Nicole, we can actually put the case scenario that you brought up and that question, Dr. Marcella, from you and Elizabeth and the YAC, we can put that on Google Classroom for folks to discuss it. And we can send you the responses from folks so you can see those and give us any feedback that you have back. So we'll include that for everyone because I know we're just about at time for today.
Yeah, that sounds great.
Okay, thank you.
Thanks.
I actually had a question.
Mhm.
So I was wondering, for individuals with in like lower socioeconomic backgrounds, if they face disordered eating because they're in like they don't have the resources, what would you label that as?
So you mean like they're not able to eat enough because like they don't have like the money to get food?
Yeah, like the money or like maybe, where they live, it's surrounded by fast food places, so there's that accessibility factor.
Mhm.
How would you label that?
Yeah, that probably could fall under the category of like disordered eating, or we also really kind of refer to that as like food insecurity. So that's what that would typically fall under because just in that general scenario, like if there's not also like an associated like, focus on like body image or fear of weight gain or something like that, that's part of that. It wouldn't be like an eating disorder. It is related to their circumstances. So we would classify that like a little bit differently.
Okay, yeah, thank you.
Mhm. And I don't know if we had any questions in the chat or not. Yeah, we had some people mention 988 as another resource that you can call if you're concerned for yourself or someone else. So yes, absolutely. Another great resource that we can reach out to.
Nicole, I wanted to add, I know one of the questions earlier was about like what causes eating disorders or like what type of trauma. And I just wanted to add to your response that like sometimes we don't know, sometimes there's multiple challenging or traumatic experiences in someone's life that can contribute to their mental health and trying to control eating or any of the various eating disorders that Nicole talked about today that can often just be a symptom of really challenging experiences that folks have had and it's often not one thing because I know I've shared with this group that I lost my sister and I spent a lot of time obviously trying to figure out what happened, what was going on for her. And it's often not one thing. And like I've talked about the glass of water before, that sometimes through the course of our lives, there's those drops of water that add to the glass before there's a crisis situation that makes all of the water flow over the edge. So, um, I think when we start to recognize some of what we were chatting about today in our friends or, in ourselves or our family members, it can be a little bit scary, like what happened to them that, caused this. And it's really not one thing, and that there are lots and lots of professionals and therapists who are focusing on this area and can help somebody pick the best treatment for them. So I just want to, add in that aspect of hope that there's a lot of folks who care a lot about this topic and are helping everyone navigate it. And Nicole, we really appreciate the resources and just breaking everything down. And definitely send us, your PowerPoint and the resources, and we'll put those on Google Classroom for everyone.
Yeah, absolutely. Yeah. Thanks so much for having me today. I'm so glad that there's this like group that's really passionate about, learning about eating disorders, but also just like mental health in general and spreading that awareness to like other, youth in the community. That's so important. And I think like youth talking to other youth about these issues can be so powerful and not just always hearing it from like adults. So I think it's awesome that this organization is here.
Thanks, Nicole. And thank you, Dr. Marcel and Elizabeth, for being on here. And I know we did run out of time, but if anyone has questions, send them to me and Lynette, and or the YPC account, and we can filter them to, anybody on this call that you wanted to hear from or ask a question from. And then to end today, I was hoping that we could all take a second just to think about a body positive affirmation and then go ahead and put it in the chat. So, y'all know I'm a mom. And I was talking in my group about how the word fat has been reclaimed over time. And I really appreciate that because I think there's so many different ways that people can describe their bodies. And so I have an affirmation that I say fat moms are the most cuddly and we're the most comfortable and to cuddle with. And then another one that I really love is our bodies are meant to change over time. We're not going to look the same that we did 5, 10 years ago. So I would say reflect on an affirmation that you have, whether it's for yourself or just for your friends or whoever. If you just think of one now, go ahead and put it in the chat for our closing today. My body takes me places. We glow from within. My body is strong. I love my black features and I never feel any need to change any part of my face to fit European beauty standards. Yes, Lynette, it's healthy to be hungry. My body keeps me alive, and for that I am thankful. Oh, I was just telling my daughter that I love my body. Thank you for all that it does. My body is a vessel for the awesome things I do. Take care of your body because you only have one. We are loved and cherished by our bodies. Clothes are meant to fit us. We are not meant to fit clothes. Yes. Feel safe in your body. You're always going to be with it. My body works hard for me and I will treat it kindly. These
Aw,
were really, really beautiful.
these are so
And
beautiful.
I hope you can take one of these with you into your day and just know that, there's many different journeys that we go through in our lives. Some of them include our body image, but that you all are perfect exactly the way that you are, imperfections, perfections, whatever you want to say, whatever resonates with you. But, your bodies are meant to change and they're exactly the way they're meant to be. I love the feedback you all are giving each other too. So, all right. Well, as always, some topics are heavier for others than not, but we'll be on the call after just if anybody wants to check in. But have a wonderful day, everyone. Oh, wait, Lynette, we
Yeah.
have the event on Monday and Tuesday. So
Yeah.
we'll email that. Tiffany, do you want to talk about it? We'll email everyone about that. But yeah, if we're not going to meet virtually Tuesday, we'll be going in person. And it is optional.
Yep,
So we'll
I'm
see
not gonna
everyone
hold
back here
anybody longer.
Thursday.
Yeah, just send out the information via email. If you have any questions, just shoot me an email. My info is on the invite. I can't speak today. Ooh, I'm glitching.
Well, if you can get a ride there or drive yourself, you get $50 for going. And Lynette will be there both days. I'll be there Tuesday. And so we won't meet virtually, but if you're not going, use the time to like catch up on stuff, Google Classroom and all those things. Lynette, anything else? Pia, Ashley?
No, other than you guys did really awesome today. And if we can give Nicole, Elizabeth, and Dr. Marcella a big round of applause. Thank you all so much for spending the morning with us. We really appreciate you all.
Thank you so
Thank you.
much.
Take care.
Thanks, everybody.
Thank you.
Have a good rest of your day.
You
Thank you,
too.
everyone.
Bye, all.
How'd that go for you, Elizabeth?